just to keep on time, Ziv's going to start continuing along genetics and stratification in GBA trials.
Thank you. We are aware that some of you need to go to the airport, so we really want to not to delay anyone. All right. So I talked about classification of genetic mutations in GBA, and this kind of like a second part of the talk that will focus on how we should use genetics in order to better stratify and conduct clinical trials. So when I talked yesterday about classification of variants, we talked about the ACMG classification, and we talked about the severity classification, which I'll just remind very quickly. But I want to bring up another classification that could and should be very important when we think about trials and when we think about drug development, which is classification by mechanism or molecular classification. So these are a couple of slides from a previous presentation, so I'm not going to go over them in depth. Just to remind that we have 3 types of Gaucher disease, and based on them, we can classify mutations. So if a patient has Gaucher disease that is a severe neuronopathic one, type 2 or 3, it means that both mutations that this patient has are severe. If they have type 1, it means that at least one of them is a mild mutation. Or you can think about it is that the definition of severe versus mild is if you have homozygous mutation and you have a mild type 1 Gaucher disease, this would be a mild mutation. And if homozygous carriage of that mutation will be a severe Gaucher disease, it will be a severe mutation. And then we have these 2 risk variants that we talked about a lot, T369M and E326K, that do not cause Gaucher disease, so we call them simply risk variants in this classification of variants. And this is another slide that I showed, how the different variants affect progression of the disease. So in this case, it's cognitive decline. So the severe mutations here in yellow progress much faster than the mild mutations in green that progress faster than non-carriers, and the same thing was seen in this study. In this study also they have the risk variant here in green that progress faster in between the mild and the non-carriers of GBA mutations. So if the outcome of a trial is cognition, and that you saw it in the talk about Ambroxol, for example, there were many, if not all of the trials, it was primary or secondary outcome, then of course you have to take this into account. You cannot ignore that, although again, we are very aware that there are individuals that do not behave according to the graphs, but as a group they do. So we have to take this into account. And a similar thing with motor progression, where there's evidence in the literature that the severity of GBA mutations affect motor progression as well. Here, for example, you can see that despite similar disease duration between mild and severe GBA carriers, if you look, for example, at the levodopa equivalent daily dose, you can see that those with the severe GBA mutations require much, much higher dose, over 800 milligrams compared to 563 in the mild ones. Also, those with the homozygous or compound heterozygous GBA mutations require a lot more levodopa or equivalent in order to control the motor symptoms. So it does affect motor symptoms as well, although we don't have really good studies on motor progression, longitudinal studies on motor progression and the severity of GBA mutations. This is a slide that Ron Postuma showed, where the severity of GBA variants can also affect the conversion from RBD to either dementia or Parkinson's disease. So again, same thing. The severity is important for disease progression. So if motor symptoms, if dementia or any related measure is one of the outcomes of a trial, of course, you have to take this into account. Now, a few years back, we did a study together with Mike Knowles and Cornelis and Andy Singleton that Hampton Leonard from the NIH led, in which we used actual genetic data from Parkinson's patients to simulate how variants that affect rate of progression may affect the outcomes of trials if you don't take them into account. And what we found out, and I'm not going to go into all of it because we've done a lot of things there, but these are the sample size per arm of the trial, and you really need very large sample size arms that in order to completely get rid of effects of genetic variants on progression. But in this specific case, we didn't look at GBA. We looked at variants with much smaller effects on rate of progression. And there was a lot of false positives and false negatives. By false positive, I mean that if the genetic variants were not balanced between the two arms of the trial, one arm progressed faster, not because of the drug or just because of the genetics that they had, and that led to false negative or false positive results, depending on which arm of the trial it was. So that can happen quite frequently if it's not balanced very well. So, and this is a relatively easy thing to do, especially with GBA. So to recap what I said so far is that GBA variants have different effects on disease progression and outcomes that are relevant to clinical trials, and therefore clinical trials should be balanced when we randomize them, so the randomization process has to be controlled, and this was done in MOVES PD, I believe, but and also in the BIAL trial that is happening now. Another point that I want to make, I think, if it was up to me, I would recommend not to include variants that are not classifiable. For example, in the MOVES PD, they did have some of those for two reasons. I mean, they can introduce noise. By unclassifiable, I mean we don't know if they're severe or mild. They can introduce some noise into the study, and the second reason is that they're just not that common. So it's not going to reduce your sample size, it's not going to affect your trial by a lot, because the most important mutation, the most common ones, E326K, T369M, N370S, L444P, and the most common recombinant variant, they are all classified, and they will account for more than 90–95% of the people with GBA mutations anyways that you will find. So that would be my recommendation, to not include variants that are unclassifiable, just to make the study a bit more clean. Then there was the question, should we include the risk variants in trials? Because their effect is so small, and they are still relatively common in the general population. For example, these two variants combined in the healthy European population, they are found in about 3% of individuals. Which means, and the odds ratio is quite small, which means that the vast majority of them will not develop Parkinson's, and it also means that you will have people that have Parkinson's that are carriers of these variants, but their Parkinson's has nothing to do with these variants. They're just there by chance because it's very prevalent in the general population. So the question is, and that could be even 50% of them in your trial, if you will. So the question is whether to include them or not. So in example, in the MOVES PD trial, they added additional conditions. If they had RBD, for example, or hyposmia, they could participate. I believe the logic behind this, maybe Pablo, you can correct me if I'm wrong, was that GBA is also associated with RBD. Therefore, it's more likely if they have both GBA, Parkinson's, and RBD, it might mean that it's more likely that it is related to them having GBA variant. Another approach could be looking at also if they have reduced GCase activity, for example, and then include them if they do. But then then comes up the question, where do you measure it, and when, and which method? So it's still unclear. So I don't have a good answer for this, but this is something that we need to think about. Now, what I want to emphasize here, and this is another gap. There was Stacy asked this question earlier about which gaps are there that the pre-competitive environment can help with, and I think this is one of them. By what I mean by molecular classification can be, I think, I like to explain it using the example of cystic fibrosis. So in cystic fibrosis, the clinical development in the last 10, 15 years has been really amazing. I'm not getting any money from Vertex, but I can tell you Vertex has done an amazing job. Because what they've done, they really did a very good classification of what their mutations are causing. So some mutations are stop mutations, and we have the same thing, exact same thing in GBA. Some mutations are stop mutations that lead to no translation of the protein, and then there are mutations that affect the the transport, to, in this case to the membrane, not to the lysosome, but same thing. And then you have, that would be class 2, and then you have class 3. These are mutations that the transport is fine, but the gating there's a problem with the gating mechanism, so that would be class 3. There's class 4 where the gating, where the there's a problem in the actual channel, the structure of the channel. Then there's class 5, which is another issue that I don't remember right now. And class 6 is those that are proteins that are unstable and being degraded fast. So they do reach the membrane, and they're just not being they're just being degraded too quickly. And based on that, they developed medications, and they explored very well, explored the different mutations in the CFTR gene to see where are the actual problems. So the most common mutation in CFTR is this one, the deletion of P in phenylalanine 508. And this mutation, for example, it affects two things. It affects the transport, but also the gating, and also the channel opening. So instead of giving one medication, they are going with combination of medications. So these are just a couple of examples with this mutation. So homozygous carriers of this mutation, they get one chaperone, ivacaftor, and one activator. And those that are heterozygous for this mutation and have other mutations, they get a combination of 3 medications. So I'm thinking we need to do the same thing with GBA, because we know that the same thing exists in GBA. For example, N370S, we know that some of it is being retained in the ER. There is an element of misfolding there, but we also know, based on some studies, that those that do reach the lysosome, there is some issues with activity. There's hypothesis that it's possibly because of interaction with saposin C, like shown here. Could be something else. But there are different mechanisms that lead to increased risk for Parkinson's. So that potentially lead to increased risk of Parkinson's. So this is something that we really should take into account. And of course, we have the mutations that lead to no translation of the protein at all. So basically, so what do we need to do? We need to, as a community, I guess, we need to define what the classes are. So the null mutations, transport issues, interaction with saposin C, membrane interaction, active site access, all kinds of things that mutation can interfere with. Then we need to think, how do we figure out what's the mutation, what these mutations do? Because I think we need to do it in an organized way, not each lab using different models and different ways to look at things and different assays. So if it was up to me, I would create some sort of a work group, maybe through Michael J. Fox, that will decide what's the best way to do this, and then which mutations to test. I would obviously start with the most common ones, but then you want to test as many as possible, because based on that you can decide who will participate in your trials, if you have a chaperone, or if you have an activator, or if you have anything else that can work for these specific mutations. The last thing I want to mention here are the modifiers. So we have these modifiers that I mentioned also in my previous talks, and they can relatively easily be taken into account when you design clinical trials. The variants that are in most of these genes are common variants, and therefore analyzing for them and making sure that the arms of the trials will be balanced as well is relatively simple as well. The same thing for polygenic risk score. And this is a slide I showed in the last presentation as well, so just to show how these variants in these genes affect GK's activity or penetrance of GBA. And this has already been shown by Pablo, but it just exemplifies what I'm talking about. The fact that venglustat had no effect on some mutation carriers, or maybe had some potentially good effect on some mutations, although we can't know for a fact because of the very large confidence intervals. But on N370S, they had a very deleterious effect. This should tell us something, and I think they did it they were very smart to analyze it this way, because it shows us exactly where we need to go. We need to go into better characterization of these mutations and classification of them, and make sure that our trials and the drugs that we're using will address the specific issues that the mutations are causing. So to summarize, clinical trials, as I said, again, this is my opinion, should include only classifiable variants and use controlled randomization to make sure that trial arms include similar distribution of severe and mild and risk variants. Clinical trial results should also be analyzed by mutation type, and randomization or analysis should take into account polygenic risk score and specific modifiers. Again, thank you to my team and all collaborators, and I don't know if we have time for questions.